The next presentation is pre-recorded and is from Mr. Kristoffer Lassen. He is an HPB surgeon at the Oslo University Hospital, and he will give us an overview about the situation of cholangio in Norway.
Good afternoon. I am very grateful for the opportunity to present some of the issues regarding cholangiocarcinoma in Norway. My sincere apologies for not being able to participate in person. I will discuss briefly some of the core data that we have at our disposal and also mention some white areas still present on our knowledge map, as well as some unresolved areas as to our treatment routines. I have no conflict of interest to disclose. This is how the country is organized. 5.4 million inhabitants in a one-payer healthcare system. There are no private actors in the cancer surgery field, and there's a 2-hour air flight from tip to tip of the country, and many patients have long distances to travel. This implies that surgery is strongly centralized, oncology not so. We have not considered this a problem so far. I am beginning to think that it might indeed be an issue we need to look at. The incidence appears to be about the same for intrahepatic and extrahepatic cholangiocarcinoma. 2.4 per 100,000 inhabitants is relatively high for Europe, I believe, but only 2/3 have been unequivocally confirmed. All in all, about 250 new cases per year. 1/3 of them have only radiology-based diagnosis. The incidence of PSC is reportedly one of the highest in the world. The incidence of intrahepatic cholangiocarcinoma has doubled over the latest decade, here shown in a red line. Extrahepatic cholangiocarcinoma appears to have a stable incidence, here shown in yellow. For comparison, I have included gallbladder cancer, which also appears to be stable, and HCC, which has also at least doubled, probably mainly because of immigration from high prevalence areas. The number of resections for intrahepatic cholangiocarcinomas indicate a resection rate of about 17%, which is exactly the same as Pim Olthoff published from a complete Dutch cohort last summer. Resections for perihilar cholangiocarcinomas with major liver resection en bloc is formally performed at all the 4 sites, but in real life there is a marked patient drift towards Oslo. A mean of 9 resections per year in Oslo probably indicates less than 15 resections per year in the country. A move to formally centralize these resections is being discussed. The rate of benign histology and 90-day mortality is in line with other publications. We have, unfortunately, no data for patients receiving only systemic therapy, not even the crude numbers. From Pim Olthoff's Dutch publication, we would assume that about 1 in 3 of those with intrahepatic cholangiocarcinoma will be treated with systemic therapy only. There is a National Cancer Advisory Board for HPB cancers, and there's a recent first edition of the Norwegian guidelines, which will be revised as early as this spring. The patients are few, and there is a high level of loyalty to such guideline programs. We are unfortunately hamstrung by poor level data for patients who are not resected. That goes for both treatment provision and for outcome. I will mention some of the controversies that we've discussed repeatedly over the years. Adjuvant capecitabine has been an issue of debate ever since the preliminary BILCAP results were presented. Following the full paper and also following the long-term results, the conclusion in Norway has been not to recommend this as a routine treatment, but as an option based on individual oncologist assessment. This, in contrast to the situation in the UK and in Denmark, but in line with the Swedes and with the Dutch. Durvalumab is not approved for cholangiocarcinoma in Norway. It has been under review for almost 2 years. Of the targeted therapy drugs, only entrectinib is approved to date. Erdafitinib is available in a compassionate use program. The others are under review or not approved. There is no established national platform for genomic sequencing. It is presently being recommended in the guidelines of last year, but so far it is not accepted as an obligatory part of the program. I think it is reasonably fair to say that this is because the funding body, that is, the government, has not worked out how to reimburse the increased costs within their budgets. We are working on this and hope to have established this as a routine for all cholangiocarcinoma patients by next year. I will briefly mention 4 clinical research initiatives: the IMPRESS Norway trial for targeted therapy, the TESLA trials for liver transplant, and the TOMCAT trial for local regional treatment. IMPRESS Norway is a national precision oncology protocol, publicly funded, offering novel anti-cancer drugs off-label as second-line treatment based on the patient's molecular profile. The aim of IMPRESS Norway is to offer targeted treatment to a higher number of Norwegian cancer patients. Cholangiocarcinoma patients with a targetable mutation and with progression on first-line systemic treatment can thus be offered treatment in IMPRESS. But while the rate of these mutations are known to be comparably high, only a very few patients with cholangiocarcinoma have been treated in the first 3 years of the trial. There is still a capacity issue. There is an established liver transplant program in Norway for liver failure, including liver failure induced by primary sclerosing cholangitis, and also for patients with established HCC. There is also a cohort protocol for patients with colorectal liver metastasis. Liver transplant for malignant tumors may be the ultimate resection, but it comes at a price. Donor graft access is reasonable in Norway, where we have a relatively low rate of cirrhosis and liver failure, but we have no living donor program for adults. So if you're a blood type B tiny woman, available grafts will be far between. I will include 2 slides from my colleague Shiraz Yacoub. These 2 TESLA trials are non-randomized trials and both aim to define a subgroup with a 5-year overall survival of 50%. The TESLA 1 trial is for the non-resectable intrahepatic cholangiocarcinomas. It has been running for 3.5 years. 4 patients have been transplanted and 1 is listed. There must be strictly liver-only disease and a 12 months lag on conventional treatment, age below 70 years, and several other contraindications. The TESLA 2 trial is for the non-resectable perihilar cholangiocarcinomas. In addition to the 12 months lag on conventional treatment, there are courses of chemoradiation treatment and stereotactic body radiation. It has been running for 2.5 years. 2 patients have been transplanted, and 1 is completing stereotactic treatment this month. Both these trials will, however, always be dependent on donor organ availability and are primarily interesting as proof of concept, the supraradical resection. Liver transplant will probably never be a treatment for a significant number of patients. I will round off this talk with a few slides on local regional treatment and the TOMCAT trial. Most patients with intrahepatic cholangiocarcinoma present with advanced disease, but even in these cases, it is often confined to the liver. That is, they have tumors that are technically non-resectable or multifocal or both. From the ABC trials, we know that the 3-year survival rate on conventional systemic treatment is very poor, and that the majority die from biliary obstruction and liver failure. This is the case for local regional therapy, where we exploit the phenomenon that malignant liver tumors have exclusively arterial blood supply. Selective internal radiation therapy, SIRT, is well known. We believe precision and tumor dosage can both be improved in a dedicated cholangiocarcinoma protocol. Hepatic artery infusion therapy with floxuridine, shortened FUDR, which is an 5-FU analog, has been pioneered by the MSK-CC in New York over more than 30 years, but very few of their patients have had cholangiocarcinoma. Recently, Rotterdam has started trials in both liver metastasis and intrahepatic cholangiocarcinoma. Floxuridine has a short half-life, and a subcutaneously implanted pump is required for continuous infusion. Floxuridine also has more than 95% first-pass effect, allowing for a high dosage, resulting in a 200-fold exposure in tumor tissue as compared to intravenous use. We implemented this technique at our center 2 years ago for the Excalibur trial in colorectal liver metastasis. So the TOMCAT trial is testing these 2 intra-arterial modalities. Importantly, we are not comparing SIRT to high pump. We are comparing the combined approach of these 2 modalities to other cohorts of inoperable intrahepatic cholangiocarcinoma patients. To assess whether we can reproduce the MSK-CC and the Rotterdam results, but with much wider inclusion criteria, we want a trial that can include as many as possible of those not amenable to upfront surgical resection. We will also include patients who have progressed on GemCis, GemOx, or GemCape, and patients with recurrent liver-only disease. The choice between SIRT and high pump will be based on vascular anatomy and tumor geography and tumor burden, as well as on comorbidity and patient preference. Of note, patients who receive high pump therapy will need to come to Oslo every fortnight for the duration of the treatment, and that will be too much for some of them. With 2 intra-arterial options, we can tailor treatment to need. So, what is on our national agenda for the next 5 years? We know virtually nothing about the large majority who receive no tumor-directed therapy, and we know virtually nothing about those who receive systemic therapy only. We have no concerted approach securing sufficient tissue for sequencing for all patients from the date of diagnosis. and we have no strategy to ensure that patients from all parts of the country have equal access to modern trials. We are working on this. It is to some extent my responsibility. Thank you so much for your attention.